Everybody to day 3 of the Patients Redefining the Future of Healthcare in Canada Summit. And I will get us going with some quick overview of the agenda, housekeeping, and a few themes coming out of yesterday in particular. Just a reminder, please share the great content that's really resonating with you on social media. And here's some hashtags you can use in order to get us trending. Hashtag Patients Redefining Healthcare. And once again, a huge thank you to all of our event sponsors, including our in-kind supporter, Axon, who has provided incredible tech support, the Zoom technology and platform for all 4 days of our event. Somebody has some noise in the background. It didn't come from me, so please do mute your microphone if you're unmuted. Just a reminder of where we are in the overall agenda. Monday, we had some amazing content, Echo Pandemics in Healthcare. Adelstein Brown was our keynote with panelists from oncology, mental health, especially youth mental health, and chronic conditions, specifically arthritis. And then yesterday, we just had an incredible session on echo pandemics in Indigenous health. I'm using the word incredible too often, but that's because there aren't enough superlatives to use here. And so big thanks to Dr. McKinney and to Marion Crow and to the panelists from Kai for a wonderful session yesterday. Today, we're so excited. We're focusing in on echo pandemics, the way forward, and I will take us through today's agenda in just a second. Tomorrow is our smaller, shorter patient action planning day, so open to anyone who identifies as a patient, caregiver, patient representative from a patient group, for us to get more into the details and the nitty-gritty of themes and what do we want to do about them together over the coming year. So I'm not going to spend time on the themes from day 1, other than to highlight the fact that there were a lot of themes coming through day 1 that relate directly to today's content. So, we have been talking about value-based healthcare for some time in the summit, as well as equity, the determinants of health. And so there were huge themes coming across from the first day on the need for a value focus, that focusing on outcomes of importance to patients, for the cost to achieve those outcomes across the continuum of care. And that means that you need to have the data and information available, accessible, usable, shared, and properly, in order to be able to understand those outcomes, and that you need to then be using this to have more integrated care with patients, that those outcomes need to be defined by different populations, and that all of this needs to be understanding both from the data side, the integrated care services, the Proms need to be understanding and addressing health inequities. And we heard some really good pieces on the data and Indigenous health and race-based data collection yesterday from Kai. If you missed it, check out the webinar, check out the recording that will be up soon, because it was great. Yesterday, the theme continued around, it is time to reevaluate and reform healthcare systems. The pandemic has blown open the inequities. It's shown all the things that people who have ever tried to use the system already knew, the things that haven't been working, which have just gotten so much worse. Data continued to be an enormous theme yesterday, and that the importance of Indigenous and race-based data standards. Some people in the breakouts were really talking about, these are important first steps. Decision makers really require this information to understand how to be convinced to resource addressing inequities. Oftentimes, however, like Dr. McKinney, community leaders and like Marion, they know what the issues are and what they need to be doing to address them and to fix them, but they often need that more specific data, disaggregated data, for others to be convinced, and so that support and that resourcing can happen. There was quite a bit of discussion in the breakouts about qualitative data as well. It was a question that came up, and how important ultimately qualitative data are, and how with community engagement, it's important to be able to dig deeper on the issues that are surfaced by the quantitative data that comes through data standards for Indigenous and race-based and sociodemographic data. There was discussion about how patient groups and communities need to access the data sets that exist and how that's currently an unaffordable proposition for most. But there's also discussion about don't wait for standardized data to start and continue anti-racism work. Just because the data is not perfect or there yet, the work has to continue. Self-determination was an enormous theme. Indigenous, this is nothing about us without us, but taken to a whole other level of Indigenous patients, people, organizations. They need to be in the lead and they need to be at decision-making tables. This is two-row wampum. We have our own boats. We learn, we work, we play with each other, in each other's boats, in each other's, but we do not steer. So this is the self-determining work that needs to be done in partnership between mainstream and Indigenous organizations, communities, et cetera. And how vital relationships are based on trust, and how allyship and relationship, allyship must be earned, relationship and trust takes time, and how important it is not to wait to act, to start the development of relationships, how it's really important to work with existing strengths and identify the steps that you can take now, both individually and organizationally. And a great quote to end on from Marion Crowe: "Rise against racism, stand with us as allies." Today, Louise will be introducing our keynotes, Ambreen Sayani and Elise Mabey. We're so excited for their content. I think you're going to love it. Then we will move into a panel on how data are vital to create a more resilient health system. And we'll have Eric Sutherland joining us for that, Haley Armstrong and Angela Johnson from Canada Health Infoway, and Eva Villalba. And then we will have some short presentations on two other working groups that we have running. Eva is the chair of our Proms working group, and we'll touch on that work as part of her presentation. And then Chenille and Cheryl Ann are with our data and integrated models of care working groups. So they'll be telling you more about some of those enablers of value-based healthcare that we've been working on together through the year. Then we'll go to breakout sessions and you'll be sent automatically to those. And then you'll be sent automatically back to the main room for plenary closing remarks by Antonella. Quick housekeeping: please keep your lines muted, your videos off. When we move to breakout, please do unmute yourself so you can participate in the conversation. We are recording the session in both English and French. And if you would like to access French interpretation, please click on the world icon at the bottom of your screen, then click mute original audio and select French. We will have moderated questions and answers different points throughout the agenda. So please, as you're listening to content, to the presenters, and you have a question, put it right away into the chat, send it to everybody, and type your question into the chat, press enter, and our moderator will catch your questions and field them to the presenters and speakers. And if you're having any technical difficulties, contact Axon Technical Support via the chat function. Just a quick reminder, there will be an evaluation survey coming out tonight about today's session. We would love your feedback to improve, and there will be a post-event report that will go out to everybody. And hold on, I think there might be things happening here. I think I am passing the microphone over to Louise Binder, the health policy consultant at Save Your Skin Foundation. And if I'm wrong, there you are, Louise. I'm not wrong. Over to you, my friend.
You're wrong. So welcome, as Leah said, welcome to the third day of what has been an astonishing group of amazing people doing amazing work, often really unsung heroes in my view. And now for a third astonishing, remarkable two colleagues who will be speaking to you today on social determinants of health. So we have Elise Mabey and Ambreen Sayani. Just to tell you a little bit about each of these astonishing women, Elise Mabey has been a patient partner since 2011. in many aspects of healthcare, from her local hospital to research to her local health authority and on policy groups both provincially and federally. In all of these, she's been aware of the needs of patient partners for connection and support. She co-founded the Patient Advisors Network, launched in 2017 to provide an online community for patient and family advisors and those interested in becoming advisors as a community of peers. She has seen the challenges and the current approaches to engaging patients and is actively involved in efforts to improve this and make opportunities for those not usually at the table to feel supported to engage. And my other wonderful colleague, Dr. Ambreen Sayani, is a passionate advocate for patient rights and has carried out bench and bedside cancer research to improve treatment and provide socially just care. Trained in surgical oncology, she has held leadership roles across multiple healthcare industries and has consulted for private sector organizations and governments. Ambreen's research is focused on the interface between social and health equity and its implications for cancer risk, treatment, and survival. She's an adjunct professor in the School of Health Policy and Management at York University, holds a Canadian Institutes of Health Research funded leadership stream postdoctoral fellowship in patient-oriented research, and that's at Women's College Hospital in Toronto. And as well, she is a research affiliate and the MAP Center for Urban Health Solutions at St. Michael's Hospital. So you are in for an amazing treat today. And without further ado, I turn it over to Elise and Ambreen.
Well, good morning, and thanks so much, Louise, for that wonderful introduction and this tremendous opportunity to talk with everyone today. We're especially pleased to be talking about the future as opposed to our COVID-obsessed present. Pre-COVID, the healthcare system was somewhat rigid and complacent, not exactly quick to change. Most of the changes took a lot of time. They were not necessarily systemic, but really tweaks to the existing way of doing things. Then there was COVID, and we learned that, in fact, change could happen really quickly as we all got dumped into doing virtual care abruptly. For all that COVID is really terrible in many ways, it's also exposed the fault lines in our healthcare system, but it seeded opportunities for change as well. And these opportunities we haven't seen for a very long time. We saw vividly that the harms were exposed in our system, especially for those that are vulnerable or living on the margins. Ambreen and I would like to share with you some of the thoughts we have about seeing the way forward given this environment.
Well, thank you so much, Leah, for the summary of the past 2 days, and Louise for the introduction, and Elise for getting us into this conversation. It's really exciting to be here today with everyone. Looking into the future, as Elise said, is always a optimistic and positive thing to do when we're all together. So reflecting back, Jan 2020 is when we had the first case of COVID diagnosed in Canada. And now November 2021, we're almost 2 years into the pandemic. We have started to really see some of the short and long-term impacts that the pandemic has had, not just on our healthcare systems, but in society as a whole. We have seen an opioid overdose crisis that parallels the pandemic. We have seen how wait times have tremendously increased, and we're just beginning to understand the implications of long-haul COVID. What we've also seen is a steep disruption in our society: stress, unemployment, economic vulnerability. And this really leaves us with the question of how do we build a resilient system that is able to withstand the shocks that we've seen the pandemic put on us? How do we move forward? What are the tangible steps that we need to take? And how do we even come together as a society to begin to envision them and take actions for change? So today, my dear friend Elise and I will talk to you about one way forward. It's the way we see we can create an ecosystem of change that surrounds our healthcare system, enabling it to build capacity and resilience to be agile to structural shocks like the pandemic. So just to set our head in a little bit of the direction that we're going to take you, I will talk about learning health systems. And the idea really is that a learning organization is going to create and accumulate data or knowledge, which it will then turn into processes and actions that will produce tangible outcomes. And for a learning health system, this really means that there are certain core values that drive that knowledge production. And within a certain ecosystem of data generation, action creation, and measurement, you're going to drive value, which is the quadruple aim. So more specifically, the quadruple aim means that we can improve health outcomes by improving the patient and caregiver experience, improving the health of populations, reducing per capita cost, and improving the provider experience.
Patient partnerships help the health ecosystem learn what's really important and how to improve. So we have to look at patient partners as essential elements in the learning health system. After all, who else but patient partners and patient and caregivers can experience the receiving of care, the navigation of the system, and identify the outcomes of care, particularly the impact on quality of life? Who else but a diverse set of patients and caregivers can highlight the differences when receiving care, navigating the system, and identifying the differing outcomes of care? Next slide. We need more than a learning health system. We need a learning health ecosystem that works for everyone. And to get there, we need patient engagement that is inclusive. So let's start by looking at some of the barriers to being able to do patient engagement and have it as an integral part of a learning health system. And let's also look at some of the inclusive patient engagement barriers that are there as well. So here's how I would group some of the main barriers or issues in patient engagement. The first is language and culture. When I started, I found the language and culture of healthcare challenging. Like any industry, there are terms and slang and tone and style of communications that are unique to the industry. And there are expectations around deadlines or meeting attendance or even dress, which is unique to an industry. And it was certainly very different from the high-tech work culture that I came from. In terms of place and space, I have patient partner colleagues who've experienced trauma in hospitals and find meeting in those places really uncomfortable. And also place and space like boardrooms are not always comfortable for people, especially as they connote power and set up a power differential from the start. And then when we're talking about practical considerations, there are the obvious ones like wheelchair accessibility, et cetera. But there are also less obvious ones that are hidden and really only understood as you get to know patient partners well. For example, people with diabetes may need to eat at certain times, and there are some conditions where people are just far too fatigued to sit for a whole hour's meeting. And, yeah.
An important challenge of patient engagement is to include a diverse set of perspectives. And when we reflect on this, our systems have been built, our institutions have been designed upon structures of oppression. And therefore, who we are, the place we occupy in society, our ability to access and use resources have all been shaped by these systems. we have created our society to be unequal. And therefore, when we drive patient engagement or knowledge creation through these very systems, we can reinforce those very structures. What we need is a deliberate effort to create knowledge and do patient engagement that is inclusive, is rooted in social justice so that it is fair. If we don't do that, we run the risk of widening health inequities. And just to put the definition out there, what are health inequities? Health inequities are differences in health outcomes or mortality rates between population groups that are a result of decisions that are systemic, avoidable, unjust, and unfair. These conditions are shaped by people in positions of power and privilege, and they create a society which places some people in conditions of social advantage and others in conditions of social disadvantage. And this is what we've seen during the pandemic. We've seen racialized neighborhoods, those people living with lower incomes being disproportionately affected by the pandemic. What we've also seen is that when decisions have been made, these are the very groups that are excluded from those decision-making tables. Now, I just want to say that some really tremendous work has gone on between communities and institutions when it came to the delivery of the COVID-19 vaccine. And there is so much that we can learn from there. For Elise and I, however, our question that we were trying to scratch our heads about was really how and why is it that patient engagement is so exclusionary the way it is currently designed? How can we get a diverse set of perspectives on decision-making tables so that we intentionally design and redesign our services to respond to everybody's needs? So we set off on a bit of a journey of listening and learning and exploring conversations with different people. At an institutional level, I don't think it would really surprise anyone that what we heard was, well, to engage with communities, our projects are based on tight deadlines, milestones, and cyclical periods of funding. So how do we sustain or even begin to create a foundation of engagement? And then in a project that's structured in that fragile way, how do you begin to integrate equity in a tangible way across those projects? Because after all, equity is really abstract. How do we do that even? How do we make it actionable? But there was such a desire to do things right and to change things where they could be changed.
So here are some of the things that we learned from the members of community, and there were many that we talked with. First of all, participation is really by invitation. We need to be invited in to participate, and we can't initiate engagement. The other thing is that stereotypes are really prevalent. There's a lot of assumptions made based on who we seem to be, or who we seem not to be, for that matter. So I'll give you an example. Many people see me as a privileged white female and would not assume that I would understand anything about living on the margins. And yet I spent 5 years precariously housed, living below the poverty line as a single parent, working 2 jobs and not knowing if I could feed my children or even keep them. Stories are not often considered knowledge, for example. They're often seen, or I've seen them, where they're used as kind of an emotional pump to prime people's emotions for what the professionals will then be discussing in a serious way. And yet, stories can contain knowledge transmitted within the narrative if one listens and takes the time to learn from them. And as a community, there is an impression that we don't have much impact on decisions. And yet, I have also experienced shifts in thinking and action as the result of some of my insights and the insights of others from community. In fact, some real aha moments that have been very exciting. We need to rethink and refocus patient engagement. It's not enough to just tweak it. We need to augment what we currently do and think about it and think about doing some things differently in order to have inclusive patient engagement and involve people with diverse lived experiences. So where do we start? We start first by rethinking patient engagement. It is foundational to a learning health system, and for an equitable learning health system, patient engagement needs to be inclusive. Let's talk about relationships. Patient engagement is fundamentally about relationships, trusted relationships, and yet it's very often handled on a sort of a transactional basis. So you have the transaction of onboarding a patient partner into a pool. You may have a transaction of putting somebody on a project. Projects by their very nature are transactional. So while relationships obviously can and do develop within patient engagement between the partners and the people they engage with and the people who place them, these relationships are more incidental. They are not developed on an intentional basis. And the development of trusted relationships takes time, effort, money, and especially focus. So one question I have to ask myself is, why should anyone engage with me if they don't know me or they don't trust me? The province of Ontario, and I'm sure many jurisdictions, have priority populations lists. And we've talked earlier in this conference about data and the need for data. There are many, many good reasons why we would have race-based data and other kinds of data of that sort for good population health planning and pandemic management. But the list is sometimes used like a grocery list when those in healthcare or in research are looking to engage. Oh, I think I'll have one LGBTQ and one person of color and one person who's precariously housed and so on. This becomes a bit like placing a person into a bucket of one aspect of their identity, and buckets in and of themselves are silos.
So I think what's really needed is, with a rethink, is a refocus. And instead of the traditional structure of sitting on top of an ivory tower where an institution is placed and looking at communities for identities that we wish to bring into our projects, instead we need to be able to look with communities. We need to have those relationships anchored with communities so that we have the trust and the relationships that allow us to collaborate, to be able to see what needs to change and how that change needs to happen. But another step in that is also, when looking with the community, where do we want to look? And so much work is based on changing the living, social, and economic conditions of community members with different social identities. And this work is so important because, in particular, of the intergenerational trauma and violence that certain communities have incurred. That work is extremely important, and that work should be led by community. And the role of being with community in that place is to be an ally and supporting community to take the lead. When we look at redesigning health systems, however, the focus of gaze can change. The locus of action is no longer community. The locus of action is the health system. And therefore, we have an opportunity to have this tapestry of different intersectional lived identities, to bring them together in safe spaces, to have conversations about what matters, what the needs and priorities are, and how can we refocus all of that to identify what changes need to happen in the healthcare system. So I would encourage anyone who does patient engagement is to talk to themselves and ask, well, why exactly am I talking to people? What is the purpose of this engagement? What are the assumptions that I have when I'm reaching out to different members of community? What knowledge do I already have? How has that been shaped? And where am I going to go with the knowledge that's created? This way, we can deconstruct our preconceived notions. And that is so important in order to be able to engage authentically. And this makes the process of engagement more inclusive. Another important question is, well, what concrete changes will occur due to my engagement? What level of decision-making can community members become involved in? And what, and quite rightly so, may they not be able to be involved in? How do we clarify in scope what that is right up front so that we are transparent about the scope of change? And being transparent builds trust. Therefore, while there is so much important work that needs to happen in building those trusted relationships with community and identifying those things that need to change in the health system, a lot of the work needs to first happen with work on self. Understanding what my worldviews are, how they've been shaped, where I want to see the world, where together with community we want to see the world, and what changes we want to make together, those need to happen while looking in the mirror.
So now let's look at inclusivity within the context of a learning health system. These are not just ideas for Ambreen and myself. We used our networks to talk with people who have diverse lived experience, inviting them into the discussions with us and inviting them to explore together with us. We learned from them that a particular purpose that would cause people to want to be involved in our case. And we identified some pathways that could lead to concrete actions leading to change. We learned that no one is interested in just talk. People want action. Next slide. Okay. We thought a lot about how to deal with the barriers that arise from place and space in particular. Well, the physical space got taken over in large measure by Zoom and, going virtual and so on. There are still aspects of place and space that we needed to address. So we thought about flipping the table. Traditional engagement includes patient partners joining a healthcare project within the healthcare environment. It may also include joining a PFAC or being a patient and family advisory council, but again, within the healthcare environment. In collaboration with people we discussed this with, we thought about initiating a community table. A community table is a safe space for community members who have traditionally been uncomfortable or even fearful of healthcare settings, and where they may have experienced trauma and ill treatment, and where they're not guaranteed of being heard. A community table offers strength in numbers and the comfort of a trusted community where individual voices are respected and listened to, and where the relationships can grow and be nurtured, where insights can be shared without necessarily having to expose vulnerabilities. This led us to innovating a way to put some of these ideas in practice, which resulted in IMPACT, which stands for Equity Mobilizing Partnerships in Community. IMPACT was co-created with the members of community. We are a community of people with diverse lived experiences who are focused on improving health equity so that everyone can have similar healthcare experiences and health outcomes irrelevant of who they are. We're based out of Women's College Hospital and provide consultation and health equity assessments to project decision makers who seek to make their work inclusive. Over the past year, we have provided consultations for many types of healthcare projects, healthcare policy, program delivery, and research, for example. So IMPACT is not only an internal continuous learning cycle, which is built in, but we also function as a learning element within a learning health system. in this way. Projects and initiatives that come to us receive a health equity lens on their work. Our process shown here includes some structural upfront work that we do together with Ambreen and myself together to prepare people for a consultation. We coach them and we ready them to discuss with community, to in fact learn the language and culture of the community table and how best to present their work so that they will derive the most value out of the discussions. The consultations occur over Zoom and result in actionable recommendations contained in a final written report. So now let's return to this slide, but having enriched the patients to include the intersectional identities and the diverse lived experiences. Now we have an equity-informed learning health system based on diverse, inclusive patient inputs.
So I think in summary, I would just like to say that Elise and I have presented to you some of the challenges associated with the pandemic in terms of health and social systems and integrating the patient voice into decision-making. We see the way forward as one where we have decision-making tables that are inclusionary, where we have an ecosystem that allows for equitable patient engagement, and that this is the cornerstone of a learning health system. However, a learning health system must exist in an environment that is conducive to change. And having that cushion, which allows it to create, recreate, and generate data that is agile and responsive to shocks, means that that cushion is able to support it to respond in that way. So what is important is at the macro level, when we're thinking of any work that is done really needs to be put on with an equity lens. We put on those glasses right up front before we start to think about values, before we start to think about pillars. Everything should come from an equity-informed lens. Population health decision-making, allocation of resources, we're thinking right up front about who is the most impacted, who is the most excluded, which policies exist, which don't exist, and how do things, what really needs to change and how. That needs to inform everything, baked in upfront. But then at the meso level, we really need to build capacity for partnerships to happen between community and institutions. So how do we nurture the trust? And we need to develop the skills, not only within community members to be able to partner with institutions, but within institutions to partner with community. This two-way skill development needs to happen in a very robust way that is genuine and authentic. At the end of the day, building capacity means sustainable funding to really do this work. That needs to happen before any changes to the learning health system can happen. Once we have an ecosystem that is driven from an equity lens, that has genuine partnerships in place, we can collaborate and co-design systems that are resilient to structural shocks like the pandemic and further things that we have yet to envision.
So thanks so much for listening to us. We hope this has given you some food for thought for the way forward, if you will. And we look forward to the questions.
Thank you so much, Dr. Sayani and Elise. I know I'm speak for everyone when I say you've given us so much food for thought and also so much hope for models for how we can do this work. So thank you both so very much. And I'm looking forward to some questions from the audience. So if you have questions, please do pop them into the chat. And we have a few minutes to dig a little deeper with our keynote speakers. I'll start with the first question, and either of you can start. What are concrete next steps patient groups can take to identify and meaningfully engage with underserved individuals and communities?
Elise, as a patient partner, I think you should take that one.
Thanks. I love being on the hot spot. So I think the first thing that we did was that we looked at the people that we knew in our current engagements, because there are people who come from diverse backgrounds, diverse lived experiences within the engagement structure, and started to talk with them and ask them if there were other people they knew that they wanted to talk with. And so you start the dialogue there. It grows very organically, and it really needs to, because it depends on what people want to do, what the issues are you want to tackle, and so on. But I think you start with where you are. You start with the people you know, and you reach out beyond that through people, through relationships. So I hope that helps answer the question.
I think it does, especially going back to the idea of trust that you both talked about today as being like fundamental. And it's a theme that, of course, has come up in all of our conversations and of course, is really important. Dr. Sayani, did you have anything you wanted to add to that?
No, I realized I unmuted by mistake, but I'm going to speak anyway because I did. I think we really banked a lot on relationships that we had in place well before we started to have conversations. So the idea of trusted relationships being part of who you are, but then also having a network of people and deriving off their trusted relationships. So it's really like this network of trust that you're reaching out into. But because you are a member of that network of trust, and you can grow and develop those further relationships.
So true. And it speaks again to the idea of community and how it starts locally, right? And that kind of work happens at the grassroots. The best type of work happens at that level, right? Because of the trust opportunities. So thank you. I have another question that came in. So at one point you spoke specifically about COVID-19. So I'm going to take us back there just briefly. Could you speak to the top challenges for people facing health inequities and how the pandemic has exacerbated them? Like what you have seen specifically with some of the communities you work with?
So I think there are lots of people who could respond really well to that, because that has been the key focus of their pandemic-driven inquiry and response action. I think for Elise and I, we would probably want to speak to the decision-making and how patients have been excluded. I think that would be where we can drive most value out of this conversation. Patient engagement has typically included a specific set of patient partners. When the pandemic hit, patient engagement came to an almost complete pause. Everybody was told to stay at home. People were told to access things virtually. And I think just in those two sentences, we can begin to see, well, if you don't have a home and if you don't have a device, well, there's absolutely no way that you're connected to a decision-making table if there was one. So those are the very things that put a complete divide into how we are doing things and those who can inform us on how to do things better. Those cracks were split apart and communities fell straight through. And the pandemic really required an innovative way to think about how do we then restructure these systems and work with those who have fallen through the cracks to help us build back up.
So I just want to add on a more optimistic basis. So one thing that I've seen is that for those who can access devices, and we have some folks who've overcome challenges to connect up and use Zoom and so on and so forth. Zoom does in some ways, or Zoom or the virtual video tends to level the playing field in ways that we haven't seen before, because we're all just little squares on the little screen, right? So there's nobody sitting at the head of the table. There's nobody in the, $1,000 suit or anything else. We're mostly all in our very ordinary clothes, and all you can see anyway is from the head up. So I think that there's been some good and some bad as well. I also think, if I can just comment on this, the barring of essential caregivers from being able to accompany their patients where they were needed had a real shock beyond the sort of patient engagement involvement. And I think what it did is it really shook people by the neck and woke us up and said, we need to be engaged, because if we were fully engaged, this will not have happened. We would have had a different kind of policy that would have allowed people to go into the hospitals with their loved ones and so on, with all the proper precautions and so on. And so we've learned a lot through this pandemic about both the good, the bad, and the ugly, but also the good. So I think we need to be aware of that and build on that.
Thank you so much, Elise. And it is a good note to end off on, because we are in this situation. So let's take the good learnings that we can. And it's true, like we can all relate to a lot of the need for these things that became so obvious during the pandemic. So hopefully we're all a bit more aware, and that's where it starts. So thank you. I, for one, can watch your recorded presentation 10 times, because I think I'm going to keep learning something every one of those times. So so grateful for your expertise and your time today. I'm going to introduce our panel, who's going to talk about specifically about data, but I just want to thank you on behalf of everyone for joining us and for your expertise again.
Thank you.
Thanks for having us.
Great. So I see some faces starting to pop up. Hello. It's my absolute pleasure to turn it over to our panel today. Just a reminder to everyone that this panel will be talking about data's role in creating a more resilient health system. So a lot of interesting learning, I'm sure, here as well. So the panel will be discussing from various perspectives the importance of health data in creating more resilient, value-based healthcare systems. So I will briefly introduce our panelists and remind everyone that their full bios can be found on our summit webpage. But just to let you know who you're going to be hearing from, we have Eric Sutherland, who is the data guy with personality and data strategist with a passion for enabling trusted insight through implementation of leading information management practices and linking enterprise strategy to practical solutions with business, technology, and data partners. He is an expert in this area, so we're really looking forward to hearing from him. We also have Eva Villalba. She's the executive director of Quebec Cancer Coalition, an umbrella group of more than 65 nonprofit cancer organizations dedicated to improving the Quebec healthcare system for people affected by cancer. Hello, Eva. And we have our two speakers who will be doing their presentations together. Haley Armstrong, who is a senior specialist of stakeholder engagement at Canada Health Infoway, most recently helping lead the National Patient Digital Health Literacy Project. One of the many initiatives led by Infoway after receiving the mandate from Health Canada in 2020. And we have her co-presenter, Angela Johnson, who is the Senior Director of Stakeholder Engagement at Canada Health Infoway, most recently leading the National Patient Digital Health Literacy Project. So we look forward to hearing about that project. And I will turn it over to our first speaker on the panel, Eric, to get us going.
I have to find the unmute button. So I don't have any slides. I'm just going to talk about my perspectives around health data. I was actually thrilled to be live at this conference a few years ago when I first met many of you. And that really sparked I remember I was invited to the stage to describe what is the role of artificial intelligence in the future of health. And to which I reflected that artificial intelligence in many ways is when you have 1,000 monkeys at 1,000 keyboards analyzing data madly in order to find the needle in the haystack insight. In a way, that's what AI is all about. So that somehow seemed to catch some resonance. And so I actually met lots of people there and actually helped advance some work around the patient's health declaration of health data rights. So that was, which I was utterly thrilled to see being published earlier on this year, because I think that is really important for patients and persons in Canada to really make it clear what your expectations are for your health data in the context of its use in Canada. I'm going to talk primarily about two main tracks. So the first track, which I'm going to build off of what Elise was just talking about around the necessity of trust. I only joined about an hour ago, but I can already, if I was keeping a bingo card of how many times trust was mentioned, I think it would be full by now. But trust is the essential ingredient in our system. The reason why your health data can actually be used in order to provision better care for yourself, in order to use the data for public health interventions, for continuous improvement of our health systems, for policy and planning, and where appropriate research, is because there's trust. And with trust, there comes some expectations of quid pro quo. And it's not that the data is necessarily, I'll be explicit, the data isn't used without knowledge, consent, things like that are represented in that Declaration of Health Data Rights. But the imperative, the work that I've been working with an expert group trying to develop a pan-Canadian health data strategy, and they really reflected that trust is an essential ingredient. We need to listen to Canadians and to communities, our First Nations, Inuit, and Métis partners, to understand, like, what does trust look like to you, such that what that looks like can be embodied in the context of the policies and structures that exist in the health system, in order to play that back to you, to say, we have delivered on the requirements of what it sounded like needed to be trustworthy. Is that enough to earn the trust? And I find that, generally speaking, at least I've read this in many reports, that traditionally there's been a very paternalistic approach where trust me because I'm doing this, as opposed to flipping the equation around. And so I know the expert group I'm working with is very loud on that point. The second thing I would say is Canada is also struck with the privacy chill, as is also reflected in one of our expert group reports, because like the decision of whether or not to share data, oftentimes individual people will say, no, I don't want to share the data because of a fear of a potential privacy breach, which is fair. Having said that, the decision of whether to share or not to share is irrespective of the likelihood or risk and the impact associated with the privacy breach. And more importantly, is irrespective of the potential good that can come out of sharing the data. For that reason, I know my own personal health record, my allergy that I have to things like penicillin and latex, in fact, I have multiple sclerosis. My primary care doctor knows that, but my acute care hospital doesn't. And if I show up in my acute care hospital unconscious or I forget something, then I may be in trouble. And so my personal expectation as a person, as a Canadian in the system, is that my data is shared in order to improve my own personal health outcomes. And yet I don't see that embodied in the system at all. And so we need to actually establish what are the policies and frameworks that allow for the outcome that we as Canadians demand. And that's why that patient declaration of health data rights, I think, was so important. The third thing that I'll spike out, I think I said two before, but third thing, but actually ties a bit to what Elise was just saying, that the necessity of using data for improving the system to protect public health in order to find the new research, to find out what are the new health conditions or the interventions that I can do in order to improve my own care, help me have access to my own health information and give me the insights that I need in order to achieve the health that I want to achieve. That's what I expect of the health system. And so I think and a lot of that work rests on the effective and timely sharing of data, the effective and timely embedding of insights and algorithms into our data structures in order that I can actually achieve the insights that I want. So that's from a data perspective, in terms of a 21st century health system, I see it being much more about me and empowerment. and I say me, everyone knows what I mean by that. It's about personal empowerment, achieving my own health objectives. And as one person said to me in a discussion a few weeks ago, which I thought captured the point so perfectly, it was a patient partner. And she said, if you do not trust me with my data, why should I trust you with my data? And I think that summed up things just so perfectly. The expectation of every Canadian should be to have access to their own health records in order to achieve what they want of their health and in the short term and the long term for their family, for their loved ones, etc. So I'm going to stop there and see how things go.
Thank you so much, Eric. That was a perfect ending. I think that quote from the patient that you were talking to, because it's a really good question and a good reflection for us for this panel. So that's great. And I'm just want to invite Haley and Angela, if you'd like to share your slides and just remind everybody that we will have Q&A at the end of all three panelists. So thank you.
All right. Well, good afternoon. Well, depending on where you are, good afternoon or good morning or good evening, but it's a real pleasure for us to be here today to discuss the digital health learning program that we've been working on at InfoWay with a number of partners, including a lot of patient partners and stakeholders and organizations. So I'm excited to tell you about that today. And so before we get started, we just wanted to make sure that there was some alignment on the definitions that we're using today, because we all know that words matter. And so I just wanted to put these up on the screen. I won't read through them, but just to align on those, and any questions after, happy to answer, of course. Next slide. Perfect. So our goals, objectives, and outcomes. And so when we started this program, we had the goal that by March 2022, improve digital health literacy for patients, families, and caregivers, and Canadians as a whole. And so our objective was to provide a set of materials and tools to provide a baseline of digital health literacy. And I think that when we were setting out, we said, you know what, there's already so many good resources out there, but they're not necessarily in one place. So how can we bring all of those materials together and repurpose them based on wherever you live, if you live province, jurisdiction, rural or urban, how we're going about and doing that and bringing those materials to meet patients where they are. And so our desired outcomes, we had a number listed, but I really think it, you know, if it can sum up, it was about leveling the playing field, and it was about a better educated population and, you know, equipping patients, families, and caregivers with the same degree of care during the pandemic as they can now. And it's not necessarily, you know, looking at an option of saying, oh, you need to have virtual care over in person, but it's just that it's part of the suite of options available. And through this program, we wanted to start off with guiding principles. I think, you know, in the early stages, as we were starting to meet with folks and saying, you know, this is where we're headed, wanted to get some initial feedback. And we thought it was important to lay out guiding principles that would help to guide this work every step of the way. And so those were collaboration, engagement, and governance. And we'll speak to a lot of those elements today in terms of how we collaborated, you know, using the co-design approach with patients, clinicians, marginalized communities, vulnerable populations, etc., as well as our engagement with various stakeholders, some that are actually here today, and our governance, which was developing an advisory committee whose members reflected that diverse culture that Canada is. So next slide, please, Haley. And this will just give you an overview of our key program activities. And, you know, I said today, oh my goodness, it's already the end of November. Where did the time go? But we actually started last winter, and we started by developing a program charter and plan, establishing the advisory committee. And then we started to look at the environmental scan and needs assessment. And we really wanted to make sure that we were going out there and finding all of those materials. And so we conducted a national and international scan to look for those resources. And then where we are now is we have just actually launched the soft launch actually of the digital learning program, which is really exciting. We have been starting to disseminate it to partners and, you know, really looking for how to make this better and where we're actually moving. So where do we go after March 2022? And this is a great slide that kind of showcases all of the levels of engagement and collaboration. We had over 51 stakeholders engaged, whether that be through interviews or focus groups. And I will point out that focus groups were conducted at every phase of work. So for direction and validation before moving on to future phases. They were conducted in both English and French. And we also, in some circumstances, you know, it's great that we're all here today. And I think that, you know, most on this call would consider, you know, a very knowledgeable patient. You know, you're involved, you're coming to conferences like this, which is amazing, but not every individual that resides in our country is actually that engaged. And so we wanted to make sure that we actually had different kinds of focus groups. So we had a lot of, you know, our activated patient community, but we also had individuals that were not part of that. And so we wanted to make sure that we had that breadth of experience as well as diversity in the opinions that we were gathering. We had 40 plus community engagements, Indigenous engagements, as well as a survey that had respondents of over 1,200, and it had representation from every province and territory and a wide mix of demographics. And I will call out today as well that a lot of the materials well, actually all of the materials that were done were completed and translated into English and French, but as well as into 6 other languages and still more to come. So some of those are Arabic, Western Armenian, simplified and traditional Chinese, Punjabi, and many more. And so as we're hearing from community organizations who have agreed to disseminate our information, they're saying, could you do this in another language? And so absolutely. And so, you know, maybe that is a call to action today, that if you're interested in some of the materials and you belong to a community organization to disseminate, that's great, number one. But number two, if there is another language that you think this material could be, you know, better suited in, please let us know as well. And my colleague Haley will run through what those materials look like, and as well as some opportunities for dissemination. Over to you, Haley.
Amazing. Thank you, Angela. And thank you everyone for taking the time to listen to us today, as well as being able to hear all these phenomenal presentations. And as we move on to the content, you know, as Angela mentioned, through extensive research, but most importantly, extensive engagement and co-design with our patient, family, and caregiver communities across Canada, we are confidently and we're able to end in 3 primary literacy areas for the program. And so with this soft launch, as Angela mentioned, starting in October of this year, we have focused on virtual care, health data access, security and privacy, and proactive health management. With our collaboration and validation exercises, not only were we able to narrow down to these 3 topics for this initial launch, of course, with plans to expand much beyond this, beyond March 2022, we were also able to validate the specific questions and topics within each of these areas that were of key importance, not only for Canadians, I think broadly, but specifically for those communities we talked about earlier. So vulnerable and marginalized communities, minority populations, seniors and mature adults, knowing again, as Angela said, a goal here is to really level the playing field, and so that as the literacy level of Canada rises, it rises in a more equitable and access friendly way. And so through this, we were able to develop 15 pieces of content covering these 3 areas. And this content and its formats was also validated and developed in partnership with patients, families, and caregivers. And so you can get a range of information, whether it's how do I have a first successful virtual appointment, checklists for things I need to bring, virtual care basics, what is personal health information, and so on. This information can be found via articles, infographics, FAQs, and checklists, as we heard loud and clear that this was the best format in sharing information such as this. Lastly, and certainly not least, we have also wanted to ensure the appropriate amount of support in disseminating this information. And so, of course, you will hopefully see us online in social channels with ads as you see them here, but we also want it to be accessible to communities and individuals who maybe have lower access or limited access to online services. And so we've also created educational content which can be printed and shared via posters or pamphlets and so forth in community centers and other organizations across Canada. With that, we have developed a toolkit to support this dissemination. So as Angela mentioned, if you, your organization, your community is interested in not just accessing this information, but sharing it with your community and network, you are more than welcome to get in contact with myself, and we can provide you with all of those tools, social posts, emails, and other content to assist. And with that, just before we wrap, you can access all of this information on our InfoWay website, again, as well through myself. I'll provide my contact details through the chat as well as in our last slide, but we'd really like to call it a huge thanks to all of the individuals, patients, families, caregivers, organizations, our advisory committee, and others who truly allowed us to get to this program what it is today, and demonstrated the importance of that patient collaboration and what it means for the information we can provide and for Canadians at large. And with that, I will close. Thank you so much, everyone.
Thank you so much, Haley and Angela. And I think I'm impressed by this and fantastic to hear about this program. It speaks a lot to what Elise was talking about in terms of language and culture being a barrier for patient participation. So these are tools that can go a long way in helping to break down some of those barriers for people. So thanks, and thanks for the opportunity to share. So we'll be back with questions, but for now I'll invite Eva Villalba to join us to present her piece.
Okay, so hi, nice to be with you all after 2 days that were so exciting and full. So today I'll talk to you about health data and system resilience from the perspective of my organization and my passions, which are patient partnership and value-based healthcare. So for those that don't know, the Quebec Cancer Coalition, we're a coalition of over 65 nonprofits in oncology that aim to give people affected by cancer a voice and improve health and oncology health policies in Quebec specifically. So let's see if my PowerPoint works. There we go. So today I'll talk about, when we're talking about health data, there's lots of things that we could be measuring. I'll be talking to you about what I think we should be measuring, which is value. And I'll go into that a little more. Whose data is it anyway? We've touched on this since yesterday. So we'll talk about it a little bit more from the patient partnership lens. And what does this all have to do with resiliency anyways? So just a quick recap. I know we've been talking about it for a while, but value-based healthcare was a concept initially brought forward in a 2006 book by Elizabeth Teisberg, who doesn't get enough credit, and also Michael Porter from Harvard Business School. And basically what they say is that value should be measured according to what's in it for patients. What is value? Currently, what our systems are doing are really measuring and making healthcare decisions based on what's good for the system or even what's good for healthcare providers, but not necessarily, are we actually doing our job in improving health outcomes for patients. So value in this perspective is really outcomes that matter to patients over the cost, but over the entire trajectory of care. So, really targeting what matters to the person that I'm dealing with. How much does it cost, not for one single intervention, but over the entire trajectory? And that gives you, sorry, I'm advancing, that gives you value. And we should be measuring value, which we're not currently doing, and actually using those measures to make better decisions. So value-based care has actually evolved quite a bit. In Europe, they've been doing it for over 10 years and actually implementing it. So it's evolved a lot. And one of the things that is necessary for that, and you'll see how it relates to data in a second, is we started with this, the patient would get to the hospital and it would always be, okay, what's the matter with you? And what's the matter? Let's try to fix it. It's you that's the problem, and we would always assume that we were going to get good quality care, but we never measured. So do we really know? Now, beyond just the medical outcomes, beyond what we do measure, which is, we're trying to cure your cancer, for example, that's a very binary, like yes or no, is your cancer here or not? But that's not all that matters to patients. It's not just, give me more years of life, but give me good quality years. And so what we're not currently measuring systematically is, yes, we're measuring medical outcomes, but we're not really systematically measuring quality of life outcomes, which are commonly measured by patient-reported outcomes, or PROMs. And I'll get to that in a second. And we're not measuring overall experience with the healthcare system. We're not actually measuring if the decisions that we're making in the healthcare trajectories are actually improving the experience for patients. And another thing that we've realized in the evolution of value-based care is that there's two main axes that are necessary for value-based care. One is, yes, measuring outcomes, which we still have work to do that in a systematic way and measure outcomes that matter to patients and not just the outcomes that matter to the healthcare system. But also the other axis, the y-axis, if you will, is care integration. And in order to properly integrate care, which is necessary for value-based care, we need to be sharing key outcomes and metrics. And that's not where we are yet. And in order to do that, what's been shown is actually in this report by Ventura, they recently had a webinar on it. And what they realized in looking at many case studies of many jurisdictions and establishments across the world that have implemented value-based care is that if you start with care integration, the outcomes follow. But if you start with outcomes, often you lack that integration. So just, food for thought in terms of, yes, we need health data, but health data, if it's not integrated and shared amongst the different providers and amongst the patients, then it's not really going to have the same outcomes. So to get back to my question, what should we be measuring? So we are measuring process metrics a little bit, like delays, waiting times, things like that. We are measuring CROMs, which are clinician reported outcomes. So like the medical outcomes. We're not measuring costs enough. And when we do, we only look at like this medication costs a lot, or this diagnostic test costs a lot, but we're not looking at costs over the entire trajectory of care. And that's something that's missing to make better healthcare decisions. And then the other two things that I'll be talking about are Proms and Prems. So patient-reported outcomes, there's patient-reported outcomes and there's patient-reported outcomes measures. And the measures are validated tools that actually exist to measure quality of life, measures of comfort, capability, and calm. Are you still mobile? How is your sexual wellness? You want to preserve your fertility, for example, measures of mental health and distress. They are standardized and validated, and they're based on outcomes that matter to patients. So out of all the things you can measure, the most important thing in value-based care is that you actually ask people, okay, what do you care about? Out of the 30 things that I can measure, what do you care about? I want to be able to keep riding my bike and keep studying and have my mental clarity. What can I do for that? I don't want to be anxious or distressed. What can we do about that? And so that's how we determine value. Is the healthcare system actually making me better on more than just, having cancer, not having cancer, or whatever other disease? So that's something that's not currently measured. And then there's patient-reported experience measures, which is how is the patient's experience within the healthcare system? Do they feel listened to, respected? Do they feel like they can make informed decisions? This can be either qualitative or quantitative. So in our working group, so with the summit, I'm heading the working group on Prems and Proms. And I think I'll pause here to discuss that a little. We had initially started to look at how patient associations can develop new prompts for diseases that hadn't yet been studied. And what we found is that it was very difficult in some disease areas. Clinicians still believe in that kind of paternalistic view that they already know what patients need and want. And they weren't really open to working and actually asking patients. So we're still working on that. In other areas, like we're working now with the Jewish General Hospital, for example, in colorectal cancer, they're very open to looking at, working with patients to see what proms and prems should be used. But what we notice is that patient associations actually are currently using prems, or patient-reported experience. They are surveying patients. They're doing focus groups. They're doing interviews with patients, often in the context of an HTA submission. But that expertise is something that we're really looking to understand better. And our working group actually asked several organizations to contribute their HTA submissions so that we can better understand, what are the best practices, what is currently being done in terms of measuring patient-reported experience. And we had several organizations contribute to this effort, such as CCRAN, CLL Canada, Ovarian Cancer Canada, Myeloma Cancer Canada, etc. And so we're currently working on that. And my two most active working group members are Raymond from CLL Canada and Christina Sitt from Lung Cancer Canada. So shout out to them. So moving on, there's a couple of healthcare data dilemmas, right? So there's this delicate balancing act, and a couple of the speakers mentioned it earlier, this balancing act between privacy, confidentiality, and data sharing and transparency. And so what's happened is that it's actually paralyzed us. Like, so much more could have been done if we just realized that we're sharing way more information with Facebook and Google. And we've been really concerned, and there are legitimate concerns over data privacy and protecting personal health data, and also the benefits of sharing that data to improve your own health, but also to improve population health. And so in Quebec, in September, there was actually a new law adopted, which will come into practice in September 2023, specifically about all personal citizen data touching privacy and confidentiality. And now within the next 3 weeks, we're actually waiting for a new bill, which has been called by the health minister a mammoth bill, because it's going to be massive in terms of totally revolutionizing the way that we deal with health data, specifically the way that we measure within the healthcare system and the way that we share that data. And so that's coming out in the next 3 weeks. And we're happy to say that we did get a chance to contribute. We also shared the personal the declaration of health data rights that will be presented afterwards. And so the voice of patients was listened to, and we're quite optimistic that this bill will actually be a good model that could be replicated in the rest of Canada in terms of how health data is treated, and also important questions like how much consent is required and for which purposes, and how that's communicated to patients, who owns the data. We've been talking about that a lot. It's really important that patients have access to their own data, and that, Eric Sutherland mentioned it before. How could we trust other people with our data if we're not even trusted with our data. So, and then how does, yesterday with the Indigenous health panels, we really heard this really clearly. Like, people need to know how their data actively contributes to improving their health and the health of their communities. And that's something that hasn't really been touched on. So getting back to patient partnership, and I'm really happy to say, if I can give a shout out to Eric Sutherland and his team at the Pan-Canadian Health Data Strategy, we were really happy to see that patient groups were consulted and really actively listened to. So in order to really have a good health data strategy, we really need to include patients as equal experts, experts in their own life living with the disease, just as much as doctors and other healthcare professionals. And so it's really important to clarify whose data is it and why do we need it? So each person should easily have access to their own health data and not have to fight to get like a piece of the puzzle from each different establishment that they visit. The analysis and comprehension of the data should be facilitated. So just having the health data like in its raw form is, I guess, better than nothing, but it still needs to be kind of translated into layman's terms. And so in order to facilitate that shared decision-making and empowerment so that patients can be active participants in their own care, it's really important to clarify the reasons for collecting the data. And this was touched on yesterday. And it's absolutely probably even more true with marginalized or vulnerable communities. But I think everybody deserves to know, what are the reasons for, what do you need my data for? What are the direct and indirect benefits? And so that needs to be communicated. And finally, the portability of data. The data should follow the patient so that we can make better decisions. And I mean, just as an example, I had a colleague who got operated in Ontario, came back to Quebec, had an adverse reaction, went to the emergency room, and it was just a tragic catastrophe, which could have been avoided if her data had followed her. And we don't even have to go between borders. I mean, if you just go to 2 different hospitals, your data doesn't always follow you. And so that can have very serious consequences on your health. So what does this all have to do with healthcare resilience anyways? So I am really happy and proud to be working with a great group at the Resilient Healthcare Coalition. And we have many stakeholders. Some of the patient groups involved are the Save Your Skin Foundation, Colorectal Cancer Canada, Arthritis Society, Lung Health Foundation, etc. And a couple of the things that we're talking about are, we have 6 main pillars. How can we improve health system resilience? And one of the more important ones is optimizing the collection, integration, and analysis of healthcare data to better measure patient outcomes and empower people through better access to their personal information. And so a resilient healthcare system is impossible without access and sharing of health data. And so I'll finish by talking about, where we go from here. So there's been a lot of talk about resilience, and I would suggest, and I know that Louise Binder also agrees with me and many of you, that we need to go from fragility, which is where we are now, or where we were before the pandemic, which was a super, super delicate and fragile system. Basically a house of cards. If you remove one card, if you change one little thing, it just crumbles. That's basically what we had. To resilience, yes, we think of the bamboo like resisting the wind and it can return to its former state. It's more robust. It can resist small disturbances. Okay, so that would be an improvement over what we have for sure. But what we really need to go towards is anti-fragility. And anti-fragility is a system that can gain from randomness, from chaos, from stressors, and learn and improve. So it can predict and prevent. For example, with the thalidomide scandal, we actually really improved drug safety. With every plane crash, which is very rare, airline safety protocols actually get better and better and better. And so that's anti-fragile. And we need a healthcare system that actively learns. And one of the ways to do that is actually the learning healthcare system that Dr. Ambreen Sayani was talking about. So in Quebec, we actually have a network of learning healthcare systems that are being put in place, which are they include patient partnerships. So you can't have learning healthcare systems without patient partnerships, and you can't have learning healthcare systems without health data. And so I think in conclusion, what we need is really to move towards this anti-fragility, including systems that can continuously learn from lessons. That requires data sharing, and it requires a partnership with patients and families and caregivers. So that's it. In conclusion, if this seems like very overwhelming, I would end with 2 quotes, which can give us a bit of hope, which is, just start small, start doing what's necessary, then do what's possible. And suddenly we're doing the impossible, or Nelson Mandela said it in a more simple way. It's always impossible until it seems done. So even though this health data piece seems enormous, I think that if we just get started with what we can, we'll see that it advances a lot better. Thank you.
Amazing. Thanks, Eva. I think those quotes can kind of be applied to everything we've heard throughout the last 3 days. So perfect ending to the last panel. Thank you. So we have a few minutes for questions, really only a few, before we move into our breakout group. So I invite our panelists, if you'd like to share your video again. And I invite anyone who does have a question to please pop it in. We do have some that we've been collecting, but maybe I'll just quickly ask Eric, I'll start with you because you were on first. You popped a link into the chat. Do you want to tell people what that is and make sure we...
Sure. So Eva actually briefly mentioned it in her comments. Thank you. The quote that I referred to earlier on was actually at a session. I'm accountable for working on a pan-Canadian health data strategy being centered out of the public health agency, but it's actually related to health data at large. And in that context, so what I put the link in the chat was the first expert group report that was published in June. Hint, the second expert group report will actually be published during Digital Health Week in about 2-3 weeks, the end of the month. And I would say there was an egregious amount of resonance with everything that Eva was just saying.
Thank you so much for that, Eric. And so maybe I'll turn a question over to Haley and Angela next, just because we can go in a bit of an order. So one of the big things that we struggle with is how we engage stakeholders like governments in some of the work that we want to do and that we want to see moved forward. So in the work that you have been doing, could you give us any insights on how we encourage holders of health data, other than the federal government, to work collaboratively on data and real-world evidence collection, analysis, and implementation strategies, and specifically with helping patients access this information and understand health data literacy? Like, can you give us some perspectives on some of the stakeholder engagement that you did on how to engage these other decision makers in moving that work forward?
I think if I'm hearing you correctly, and I'm just going to kind of rephrase to make sure, but it's in terms of how to advocate your position to other levels of government other than the federal government. Is that accurate? So you'd be talking about perhaps like provincial or municipal governments in that way?
Exactly,
right?
Exactly.
Yeah, so I mean, I always think the best way is actually looking for your local representation. So if that is your local MPP, or even MP. I know sometimes we talk about the federal government. The federal government is quite big, but there is actually individuals that represent you in your own riding. And so oftentimes the best way to advocate is to actually go to that person, and because they represent you in your community. And so they will meet with you. You could tell them your position, tell them all of the opportunities that you have. And I also often think that you can encourage in that moment to say, I think it would be really great if these levels of government could work together, or how could I help you to move this forward? I always often think that, you know, politicians, especially when you're on that level or when you are dealing, is how can we do this together? What types of advice do you have for me, even as a person that's in your office? How could I move this forward in a more holistic way. And oftentimes, I think you'd be surprised at some of the advice that you might be given and you building that relationship. I know we've heard a lot about trust here today, and I think that's no different. I think in any engagement, whether it's with government, whether it's with individuals, community organizations, talking to a diverse audience, marginalized populations, that is what I would encourage, is starting to build those relationships with elected leaders and letting them know where you stand on specific items and letting them know that you're available and you're a trusted source that can provide them more information.
Thank you so much, Angela. I know that's a big question, and so part of the understanding how to put your message forward, I think, is something that patients might struggle with. So thank you. And we don't have a lot of time, but I will turn it over to you, Eva, because I know you do a lot of work in what Angela described, and we know that moving value-based healthcare forward is a challenge, right? It's a shift in paradigm, essentially, in how we look at healthcare. Can you speak at all to this question in your perspective, and how can we, or how would you say those of us listening can help to move these things forward?
Yeah, so just to add upon the previous question, one of the things that we've done is having those talks with government people, at the provincial level regularly, not after the fact, after we've done all this work, but really in the beginning, like, this is what we're thinking of doing. What do you think? Is this aligned with your priorities? How does it, sometimes, I think that we as patient groups are often ahead of the game, like we're more innovative than the government wants to be, but it's that constant kind of pressure in a nice collaborative way, that's like we're not here to push you, but we are going to make sure that you deliver on what you promise. So let's, how can we help? So we've done a couple of things in terms of, for example, consulting more broadly than the government is actually doing, or instead of the government consulting with 65 organizations, well, we can kind of consult them and then bring that summary to the government. They prefer that. So that's like one way that we can actually help. And I think that, but that also makes we have a great responsibility to make sure that we're actually representing diverse voices and not just like the privileged few, and if these past few days have taught us anything, is, we have to make sure that when we do have the privilege of being able to engage with, key government stakeholders that can actually move, whether it be the value-based healthcare agenda or like health data or any other topic, that we actually make an effort to make sure that the voices that aren't as loud also get heard. And so that's something that we've been working on. And I think that it's really great to consult more people and to work, to find that shared objective. Some things might be different, but we do share a lot of common objectives, and seeing government as one of those partners that we can actually have common objectives with.
Thank you so much. We do have to move on to our next presentation, but I just want to thank you all again, and also remind everyone listening that you all have been such spectacular supports of the summit work. So I know that if people have questions, and if we do have further conversation on this, we will be coming back to you all. So thank you, and hopefully you can join us for some of the breakout sessions later. So thank you again very much. And it's with great pleasure that I now turn it over to our final speakers of the day. I misspoke earlier when I said we were moving to breakouts, not quite yet. We do have a short presentation from our working group members, in addition to what Eva shared about the Proms working group. So I invite, first up is Chanel Patak, the chair of the data working group and founder and CEO of Zamplo. And following him will be Cheryl Ann Simoneau, a member of the Integrated Models of Care Working Group and founder of the Chronic Myelogenous Leukemia Society of Canada. So welcome to you both. Nice to see you, and thank you.
Thank you, Antonella. I'll share my screen and then we could start. Just 1 second. Great. Okay. Can everybody see my screen? Antonella, can you see it?
Yes, Chanel, thank you.
Okay, thank you. Welcome, everybody. As Antonella mentioned, I'm the chair of the Data Working Group, and we formed this working group in at the 2019 Patient Redefining the Future of Healthcare in Canada Summit. And the working group is comprised of a small group of volunteers from a diverse patient organizations and citizen groups. Most of us have lived experience as patients and caregivers. And we set the task to come up with a declaration of personal health data rights in Canada. It's a document that provides a uniform understanding of what our rights are across the country. And a bit about my background is my background is in data analytics. So I started a social enterprise called Zamplo, and we allow individuals to collect their entire health data set from all practitioners and share it with whoever they want. And in essence, we want to democratize care by giving you full control of your health information. And so those learnings and also my background helped in my advocacy work. My late wife was diagnosed with stage 4 lung cancer, and we used self-reported data and also our medical information to find patterns to influence our decision-making. And the frustration we had was the access to our own health information, and not just medical information. This is all medical information, our optometrists, our dentists, psychosocial, this is all defined as healthcare. And I think that's important to highlight that, because we often think about the government-run healthcare system when there's a lot of peripherals around that also hold our health information. And so I've been a patient advocate for over 5 years, and I give talks on the power of health data in your hands. And so my experience of the resistance to getting health data is not unique, as we've heard. And so the members of the working group and others have also experienced the same. And what we found is in Canada, there's confusion about the fundamental principles of personal health data. And we feel that there's a consensus needed amongst the citizens and patients about health data rights in order to harness this power for personal health gain and also help the community. So our working group decided to tackle the fundamental question of who owns personal health data and what does this mean for patients' access to the data. And so we went off and we scanned the ecosystem of reports and papers from national and provincial level, also European legislation. And we consulted with Canadian health laws and privacy experts. And that's how we started drafting the declaration. We started that in 2020. And then by end of 2020, we had our first draft and we published it in early 2021. We'll be at the end of this presentation give you links because we are still looking for advocates as well as endorsement. And the document is an aspirational document aiming to remain relevant in the future as our society moves towards digital health. So one thing to note is we also include, for example, genetic material like DNA in its definition of personal health data. So as I mentioned, it is a living document. We incorporated feedback from 2021 and published it. We have a number of patient organizations who have endorsed the document. And what we found in our investigation is that there is a legal foundation from the Supreme Court that people own their personal health data. However, I believe possession is 9/10 the law, and our custodians really have control of this data. We've heard complaints about resistance to gate this data, or even and also the cost. And so the declaration is a tool for education amongst patient organizations and patients, and then we want to also use it to engage provincial and national government stakeholders. There are 11 rights that we've included here, and I won't go through all of them, but I wanted to highlight the spirit of the declaration. One is you have to be informed when data is collected, give permission, There's a separation between de-identified and also personally identified data. You should benefit from the data collection in some capacity. And also you have the right to object or restrict the processing of that data. With the intelligence of health data, you could infer a lot of medical information. And so that's very important. Being in tech, you could actually record a person's voice and find out if they're predisposed to Alzheimer's, for example. So it gets very fuzzy what is defined as health data and what's defined as derived health data. So this is going to evolve as we learn more, and the declaration will evolve. One thing I want to highlight is number 10, which is the right to erasure. It's not retroactive. And also this is a declaration, is non-binding. The research ethics boards, privacy laws will take obviously priority and precedence over this declaration. So we launched in mid-June 2021, and we have a diverse set of stakeholders and patient organizations have supported us. And we're looking for more because we want this to be a national recognized declaration. And we feel that the declaration is a conversation starter amongst the health data ecosystem. Because I think once we start talking about data and data rights, we can infuse more trust into the healthcare system. And part of our next steps is to create a report card for data custodians to assess and share their progress in terms of implementing the rights. And we want to do this on an annual basis. So we don't have teeth in the document, but we want to create accountability and also grow. So this is not a one-off exercise. We need support to nurture this, to make this into a movement. Also, what we've had response by is that we've had various health stakeholders on the provincial and national level look at the document, understand it, and possibly use it as an input into policy. And so as we get more credibility, I think we have more weight. If you want more information on the declaration, please contact Aaliyah. And also, if you want to see links or review the declaration, it is available in both English and French. And the links are here, but of course, we will share it through email. Just email Leah, and we'll be happy to. Thank you. Should I hand it back to Antonella?
Thanks so much, Neil. Yes, I'm actually going to hand it right over to Cheryl Ann, okay. But really appreciate your leadership on this as the chair of the working group, and excellent work and exciting. So I'm sure we'll be talking more about the declaration in our work tomorrow too. And thank you, Cheryl Ann.
Thank you. Now I'm going to see if I can share my slides. So give me a second here. I'm just going to put this in. Great. So my name is Cheryl Ann Simoneau, and I'm the founder of the Chronic Myelogenous Leukemia Society of Canada, so CML for short. And I'm also a member of this Integrated Models of Care Working Group, which I'll refer to as IMOC for now because it's a mouthful. So the IMOC group was formed in 2019, the last time we were all together physically for the 4th annual summit. And these are the purposes and key elements of integrated models of care that the group identified as important from the outset and included in the group's terms of reference. And as you can see, the models that specifically address Indigenous health and healing were of particular interest to us. I'm just going to see if I can advance this. Let's see. Yeah. I would like to thank the members of this group: Louise Binder, John Sodden, Jennifer Graham, Margaret Peters, and myself. So last year, we determined that we have a great deal of alignment with the WHO's integrated people-centered health services framework. So we identified a number of Canadian and international examples of integrated models of care, including some that focus on Indigenous communities. So this is the working definition that we used to guide us in our work. So this year we learned that in 2016, the World Health Assembly adopted the WHO's framework on integrated people-centered health services, and that Canada provided input into it and supported its adoption. And in 2017, the WHO's Global Service Delivery Network was launched, which includes as an objective advocating for integrated and people-centered services. So we are working on a draft consensus document for patient groups that adapts the WHO framework and material to reflect Canadian realities and examples. And these are some of the examples of integrated models of care and mechanisms for integration between levels of care. Ontario Health Teams are another early example of regional integrated models of care that came up in our survey. And I just wanted to mention in this, I'm working on a project specifically related to CML, so you can kind of figure out how does this all work within what Eva was presenting to us today for the value-based healthcare, that we need to be able to do these integrated models of care in order to have this continuum of care regardless of where you are in Canada. So to that extent, I'm working with Dr. Shannon Jackson, who's a CML doctor out in BC, thanks to Eva, who is going through the VBHC program at in Austin, University of Texas. And what we're doing is trying to come up with an IMOC for CML, for example. So regardless of where you are in North America, and it could actually spread out among the world, there is a cycle that you'll go through once you are diagnosed with CML. It'll include seeing physiotherapists, social workers, nutritionists, everything that you need in order to start you on your journey through CML, because it's not just about taking the oral chemo drugs that we have. It's about being able to keep taking them consistently and improving your quality of life while doing that. So it kind of gives you an idea that I want to make sure that we all know the train is on the track. I mean, it's actually left the station, but it's going slower than we thought, but it's going somewhere. So we are trying to identify who are the Canadian leads working on the WHO's Integrated Person-Centered Health Services Framework, who represents Canada at the World Health Assembly. And also, if you have any tips or ideas, or if you're a patient caregiver or patient representative that would like to join our integrated model of care working group, please get in touch with us. So I will take it back over to Antonella.
Thank you so much, Cheryl Ann, for that update. And for those of you who are interested in joining either of these working groups, this is something that, again, we'll be talking about tomorrow, and integrating our learnings from this year's summit into the work that these groups are doing. So thank you both so much. And we look forward to talking with you in our breakout and in our session tomorrow. So we are going to do breakout rooms now. We're running a little bit late, but to stay on schedule, we are still going to all come back to this main room at 2:20 Eastern time. So at that point, you'll get a 5-minute notice that the breakout group session will be ending, and then we'll all be brought back to this main room at 2:20 Eastern time, so that we can just wrap up this component of the summit together, since tomorrow is just a working day for patients and patient group representatives. So with that, thank you, and we'll be sent out to our breakout rooms automatically now.
Hi, folks. Some of us just joined back here because our group was only a 3-person breakout room, so we thought we'd come back here and be added to another group.
Yep.
Okay. Yeah, I haven't been assigned to a group.
Because we didn't even have yesterday and the day or the previous time I was able to see all the other breakout groups, but now I can't. So
Oh, perfect. Okay, and then it's inviting.
Oh,
I think I'm moving on to room 2, so see you later.
all right. See you.
hi Eva, how are you doing? Oh, hi Eva.
I'm back. Okay. Room 4. I was by myself in room 7. Let's try room 4.
Okay.
Okay, so I have been tasked with the closing remarks for the summit. So I'll just take a couple of minutes to make some acknowledgements and gear us up for tomorrow's work. So first of all, thank you. It's my honor to thank all of you for attending the 6th annual Patients Redefining the Future of Healthcare in Canada Summit on behalf of the Canadian Psoriasis Network, Save Your Skin Foundation, in collaboration with partners in Indigenous health and our steering committee. So to say the very least, the last 2 years have challenged us to think about our health and social systems in ways that we couldn't have imagined before the pandemic, though I'm told that some of us could. And the issues of sustainability and the effectiveness of healthcare systems and healthcare delivery were made exceptionally stark. And the fact that social factors are fundamental aspects of health that must be integrated into how we redefine the future of healthcare became undeniable. So our speakers have given us so much to think about and to take action on, and we're grateful to each of them for their passion, commitment, and expertise, and for sharing these with us over the last week. I know I'm speaking for all of us. We look forward to taking what we've learned from them and integrating it into our summit working groups. And we have a lot of people to thank for making this event happen. So I'm just going to dive right into that. Thank you so much, Leah, for your very hard work facilitating the steering committee, the working groups, and for being such a fantastic moderator, as always. Thank you to Madge Gadban, Chantel Burrows, Natalie Richardson, and Marianne Gagnon for their hard work to help organize this event. And I want to personally thank Louise Binder, Sharon Clark, and Kathy Bernard for their leadership again this year and helping to make this work happen. I want to
personally thank Antonella Scali, who
thank you.
is incredible, and you put so much time and effort into this. So
thank you.
Someone needs to thank you. I'm doing it.
I appreciate that. Thank you. And I want to thank our committed facilitators and acknowledge them. Eva Villalba, I think everyone knows these folks, but Eva Villalba, Cheryl Ann Simino, Martine Elias, Megan Mahoney, Joanne Harabas, and Ron Rosenes. I'm pronouncing names probably incorrectly, and I apologize for that. We're grateful for your time and dedication year after year. And I want to acknowledge our sponsors again in alphabetical order, very importantly, because we do have free reign to do what we will with this summit, and we're grateful for that freedom. So AbbVie, Amgen, AstraZeneca, Bristol Myers Squibb, Janssen, Leo Pharma, Merck, and Novartis, thank you again for making it possible for us to come together virtually this year. Thank you to Innovative Medicines Canada for their support of our working groups, and a huge thank you to Axon for providing the platform and technical support for this year's summit and pre-summit webinars. Thank you to the working group members who will integrate our key learnings from this year into their action plans for 2022 and beyond to continue to move us closer to a value-based healthcare system that's built on the foundations of human rights-based data collection, sharing, and use, patient-reported outcomes as defined by patients, and integrated person-centered models of care that ensure that specific populations across Canada achieve the health outcomes they want, need, and deserve. We also look forward to continuing to advance this work in collaboration with our partners in Indigenous health. So we're sending out an evaluation survey about today's event. So anyone who's not already involved, I know there's a small group of us left here, but if you're not already actively involved, you can sign up for our working groups by responding to that in the survey. As a reminder, recordings of the summit presentations in English and French can be found on the summit landing page, along with other materials related to the event. Our pre-summit webinar recordings are there, and reading materials. And we'll also be sharing this year's summit report with everyone that captures highlights from this year, so you can look out for that as well. And for those of you who are part of the patient and caregiver community who will be joining us tomorrow, we look forward to rolling up our sleeves together, as I mentioned, to reflect on the key themes from this year's summit and to help inform the priorities for the summit working groups and the summit planning committee for 2022. So thank you again so much for your participation, for the work that you do to help create inclusive, fair, and thriving healthcare and social systems in Canada. It's an honor to be among this group, and I look forward to working with you tomorrow. And thank you for the time to share these last words. Any last comments from you, Leah, as our official moderator?
I love everyone, and I really appreciate those of you who are still here. But no, it's honestly a real honor and pleasure working with all of you, both here within the summit environment and on the working groups. And I hope that we can do this in person next year, because I miss seeing you, giving you a hug. And thank you again, Antonella.
This part is usually the love fest at the end with like the lingering patient group. And I feel like it's like happening virtually. So it's a good vibe, and thanks everyone so much, and see you tomorrow for those of you who can make it for sure.
See you soon, everyone. Thank you again.